Hello, I'm Dr. William Nordquist. I'm making this video specifically for physicians. And as you see, as we go through this video, the reason why I think this is so important for physicians, or knowledge that physicians should know. First of all, my background is I'm board certified in oral implantology, and I have postdoctoral master's in oral biology with a major in general and oral pathology. And the reason I bring this up is because the type of background I have allowed me to see some concepts in the relationship between periodontal disease and systemic disease that I think is very important for physicians to understand. The more I got into this subject, the more I realized the difficulty in getting concepts from research to clinicians because of the complex system that we have of periodicals. That you can't just go to the library anymore and get a periodical and read it and be up to date. Now you have to go on the internet and go to PubMed and then try to figure out how to get these articles paid for, because if you don't belong to the specific journal, or if you're not a researcher for whatever reason, sometimes it's very difficult to get each article. And then the vast volume as well of periodicals to be able to keep up on various subjects. About 5 years ago, I became more aware of the relationship between oral and systemic because of failures and implants that I was having over the years. And I couldn't understand why a lot of my patients with a lot of missing teeth also had many chronic inflammatory autoimmune diseases, diabetes, heart disease, Alzheimer's, and cancers. And so in my quest to find the answers to this, I started searching, and I had purchased a brand new microscope that allows me to look at microbes in gingival plaque at 5,000 power, and being over the number of years began to understand what the problem was and which bacteria was causing the problem. And as we go through this video, you'll begin to understand why this subject has been so elusive for so many years. But there is definitely a relationship between periodontal disease and systemic disease. And we'll get through this video and you'll understand the urgency that prompted me to make this video. I hope you enjoy it, and I hope the knowledge helps you understand the oral systemic problem. Thank you. Hello, I'm Dr. William Nordquist, and our presentation today is Periodontal Disease, the common denominator in the spectrum of chronic inflammatory diseases. This subject has been alluded to for at least 20 years, and we've wondered what the relationship was between periodontal disease and systemic disease. We've had many articles that have shown relationships between the two entities, but until only recently have we known specifically the mechanism of the relationship between periodontal disease and some of the systemic diseases. And that's going to be the subject of this talk today, or implant failure for that matter. The World Health Organization, the Global Status Report on Non-Communicable Diseases. There are key messages here in this report. Non-communicable diseases are chronic inflammatory diseases that we're discussing in this presentation. It's a worldwide epidemic. The epidemic has serious negative impacts on human development in human, social, and economic realms. These diseases reduce productivity and contribute to poverty. These diseases create a significant burden on healthcare systems and a growing economic burden on country economics. These diseases impede progress toward global goals. They must be tackled if global development agenda is to be realized. The autoimmune or chronic inflammatory disease epidemic. It is a worldwide epidemic that's occurred in the last 100 years. 80% of the population has one of these chronic inflammatory diseases by age 60, if not many of these diseases. So what changed in the modern world? How does it affect the practice of dentistry? How to include treating these diseases in the dental practice? These are keys that we're going to go over step by step in this presentation. Are these chronic diseases really non-communicable diseases? What is the cause of this disease? Is it the body's altered terrain that contributes to a weak immune system? Or the actual microbes themselves? Are they involved in the disease, or both? We're not going to talk too much about the terrain, but the terrain does have everything to do with this. But in this presentation, we're going to mainly talk about the microbes and what you can do to get rid of those microbes. But another presentation will talk about how the modern diet and sugar and refined carbohydrates have an influence in changing the microbiota of the mouth, which skews it toward disease instead of health. If you want more information on the health issues and what is it about the modern diet that causes the problems we have with decay and dental disease, and check out Weston Price's research. You can just be Googled online and you can find a lot of information. Plus, I've had patients that are of African origin, and they claim that their relatives back in Africa don't have the modern diseases that we have. It only occurred when they moved here to the more modern diet that they started developing diabetes. And as you know, African Americans have more of these chronic diseases and more problems than the average. What we're going to discuss is how I got into the study of chronic disease, and I mainly got into it because of implant failure. I found that many of my implant patients, they had failures, and most of the implant cases I did with many missing teeth because of periodontal disease also had many of the chronic inflammatory diseases. So about 10 years ago, I started studying these microbes with a microscope. And this was the same time the Surgeon General came out with his report in 2000, and I figured it'd be time for me to start studying this in more detail. So I'm going to show you some of these patients that I've seen over the years, and some of these are my patients and some of these are patients I have studied as an expert witness. And I want to show you that the root cause of these problems is not the dentist and is not the technique or anything that anybody did wrong, but it just happens to be that these patients have an underlying cause or chronic inflammatory diseases and are immunosuppressed and cause the dental implant failures. Some resulted in lawsuits, but they all cause problems. First such case was an onlay hip graft that failed. And this case was sent off to a Midwest, very famous, in fact, is one of the most famous implant dentists in the world. And I'm not going to mention names because it's really not important, because everybody has failures and every technique that we use have failures. But this is a case where a patient owned a bar and he was a heavy drinker and smoker, and he went to have a hip graft done. Actually, he did it on his own. I had no idea he was going to get this done, but I had talked about this particular individual, and so he went back and had the hip graft and then showed up in my office. But you can see from the upper picture compared to the lower picture that graft completely failed within about 6 weeks. And as I look back at that case now, I attribute it to the underlying cause that this patient was immunosuppressed because of his chronic diseases. He had heart disease and diabetes, and also was a heavy drinker and smoker. And that was the cause of his implant failure, not the technique, not the clinician. Another case that a clinician had completely finished 6 root forms, and during treatment there was problems with infections with one periapical lesion. There were a couple sinus problems where implants ended up in the sinus because the bone didn't take, and when a patient bit down, it shoved the implant up into the sinus, and then the patient initially was diagnosed to have removable, but during treatment she elected to go to fixed teeth, which required sinus elevations. Well, there was problems with infection with the sinus elevations. Well, as I look back at that case, I received this case from a dentist who had extracted quite a few of her teeth because of periodontal disease. And when you look at those x-rays, she had severe periodontal disease, and as I know now, was extremely immunosuppressed because of this. Well, I was unable to get her into fixed teeth because we had continued implant failure. So she went to an oral surgeon who removed the implants that I had placed, and you can see in the lower did 2 hip graft surgeries. In the upper right, you can see one of the remaining implants that he couldn't get out because it was back too far. So it remains a marker. So as we follow through this case, we can see how not only the previous dentist and then my treatment, but also the subsequent treating oral surgeon's treatment all failed on this patient. And it's all blamed on the chronic underlying immunosuppression that we're going to learn about in this presentation. Now on the left-hand slide you can see that there's implants placed in the upper left, but you can see there was no bone gain from a hip graft that this oral surgeon had done. And the right side of the jaw, no bone took. In fact, as you can see, there was a net loss of bone when you compare that to the implant that's still there from the implants previous, before he extracted the other implants. And on the right-hand slide, you can see that he placed the implants into the second hip graft surgery, which completely failed, and actually had a net bone loss. And this case really was a very traumatic case to go through. It was one that I went through 10 years ago and blamed myself for it and felt that I probably had done something wrong. But now as I look back, all three dentists involved in this case experienced catastrophic failure. And it wasn't because of anything anybody did wrong, but it was because this patient had severe periodontal disease to begin with, and for the reasons we're going to discuss, had implant failures for two dentists, and of course lost all her teeth from the first dentist. So we're going to learn this as we move along with this presentation. Here's another case in point on the upper left. There's a CAT scan model that's flipped upside down of a maxilla. And this case went through extensive bone grafting. Subsequent to having implants fail quite a few years ago, and she went to an institution. They did extensive hip graft surgery by one of the most famous oral surgeons in the world. And you can see on the lower right that this is again flipped upside down, that only one implant remains. The patient lost all her implants plus all the bone. This is the x-rays of this case, and you can see there are only 3 implants left from the extensive hip grafts. And the lower right is the mitigation of this case with what we call custom endosteal implants with root form implants. By this time, we understood that it's very important to follow these patients extremely carefully, and we understood chronic disease, and so we were able to maintain this case just this way for 7 or 8 years since we completed that case. But with an understanding of what chronic disease and immunosuppression is, that we can actually maintain these patients and treat them, and if they have a little infection, we know exactly. So what was the common denominator in all this failure? They all failed due to immunosuppression and infection. An understanding of chronic disease could have prevented all these failures from the beginning. The disease became the enemy, not the dentist. The doctor and the patient become a team dedicated to eliminating the disease so that you have implant treatment that's successful. As we move into discussion, we're going to talk about diminished cognition, dementia, and Alzheimer's for a short while. And all of us have wondered over the years, you know, we have these sobering questions concerning why do patients with a lot of missing teeth have one or more of these chronic inflammatory diseases? And what is it about the fabrication of dentures that makes it so difficult for dentists to want to do? Most dentists, you know, after they do a denture or two and then have to give back the money, don't want to do dentures anymore. Well, why is this? In a lecture I did with several years ago, one of my co-lecturers, Mark Davis, mentioned he noticed that patients' brains be located in their teeth because the more missing teeth they have, the more, he said, stupid or mentally challenging these patients seem to be. And it's all too true, is that we've noticed that patients with a lot of missing teeth also have diminished cognition and some in the beginning dementia, and a lot of them follow on into Alzheimer's disease. All chronic inflammatory diseases are related to the same process. It's bacterial invasion of an open wound. In the case of periodontal disease, it's the periodontal pocket, or the lesion itself is a very large wound indeed for patients with moderate to severe periodontal disease. Then you get an inflammatory reaction, and then there develops an offensive and a defensive battle between the body and the microbes. Now, spirochetes, even though there's, we call the red complex for severe periodontal disease, and all those bacteria are actually necessary in the disease state. But once the disease state starts and spirochetes proliferate out of control, they become the instigator, I feel, in most of the chronic inflammatory disease. They're able to produce immunosuppression, which we're going to talk about later. There's a never-ending immune response when spirochetes are present in the tissue, which results in chronic inflammatory diseases long-term. Now, when you're studying the immune system, like we're going to be showing you how the normal immune system works, and then we're going to show you how immune-suppressed immune system works. But to understand pathology, you first have to understand how the immune system works in the beginning. So what you're seeing here is cells that are located in pus from a draining abscess from an abscess tooth, and it's tooth number 31, and there's a periapical lesion and also a periodontal lesion where this abscess is draining from. And what we find is we find these cells full of these vesicles, and the body is actually going in and phagocytizing bacteria and turning them into little packages and then moving it out of the body through a draining abscess. And this is how the normal immune system works, is it actually moves the bacteria and infection from the inside of the body to the outside of the body. In this recording, just ignore the fact that you see black around the edges, but I just wanted to show these particular cells. But you can see that each one of these immune cells has bacteria within the cytoplasm. They almost look like lobster traps, in that once these bacteria get inside these, they don't seem to be able to get out. And I don't see much phagocytosis. In other words, I don't see these cells chasing these bacteria down, so they must have some mechanism that allows the bacteria to get inside the cell but not out. But this is another sample from the draining abscess of tooth number 31 that I showed in the previous slide, how the normal immune system works, where it traps the bacteria, and then the pus, it gets into the pus, and then it goes through a draining fistulous tract to outside the body. And most autoimmune diseases and heart disease and the atherosclerotic lesion, the same kind of inflammatory response may occur, although you're going to see how the immune suppressed system works, where actually these things don't do phagocytosis like this normal cell. But in the lesions throughout the body, they have no way of exiting the body as it does in the mouth. In this video, you see one immune cell, and if you follow this very carefully, you'll see a little bacteria that's very fast moving. It moves around the cell extremely fast. It's hard to tell what kind of bacteria this is because it's something that we have not been able to identify. But it went up to the 11 o'clock, and you can see it now penetrating out through the cell wall. And it actually increased its size by tenfold, and now it just went back to the shorter form. And for some reason, this particular spirochete is able to transform from a shorter version to a longer form. And you'll see it go back to the longer version of this in a second, and then right now it disappears. The significance of this is that oral spirochetes can actually change forms once they get into the immune cell, and then they work their way out. So research has shown that these spirochetes can actually get inside and outside epithelial cells as well. And so spirochetes are a very unusual bacteria in that they're very... In this audio sequence, we're going to show you how the immune system works when it's suppressed. And these we're taking into gingival sulcus. And what we're seeing is various bacteria. This happens to be a trichonomad, and we just saw a spirochete. But as you peruse this particular slide, you say multiple spirochetes and many other type of bacteria. Now here's an immune cell. And what you have is a spirochete. It looks like it's attacking the immune cell. And over the years, as I've studied this, I've never seen any of these immune cells with any bacteria in them at all. These, like I say, come from plaque samples, and those plaque samples, the immune cells are totally suppressed. They're not doing phagocytosis, they're not doing anything. And the bacteria in and around them survive very well. And to take away knowledge from this cell, and these immune suppressed cells that we're seeing here, is that in stark comparison to the last 3 slides that we saw videos where the immune system was working well, where the immune cells were filled with bacteria and being phagocytized and neutralized, when we look at plaque samples from the mouth in periodontal disease, that there are so many immunosuppressants being produced by the bacteria that the immune cells are doing absolutely nothing to kill the bacteria. So when we look at immune suppression, the gingival sulcus is a great example of what is probably happening in all the chronic inflammatory diseases, wherever they are found in the body. Spirochetes and other bacteria actually get in the immune cells and can produce immune suppressants, which suppress the entire immune system of the body. So it's very difficult for the body to fight cancer or anything else as long as we have spirochetes or periodontal disease and a spirochetal disease. Immune suppression seems to be the common denominator in all the chronic inflammatory diseases. If you check for C-reactive protein, that'll be high. If you check for vitamin 2,5-D, that will be low. So it seems to be immunosuppression seems to be the common denominator in all the chronic inflammatory diseases. For many years I discussed in my lectures what I called multiple missing tooth syndrome. And what I noticed that people who have a lot of missing teeth that need a lot of dental implants also had a lot of missing teeth. And multiple missing teeth is a proxy for bone loss due to periodontal disease. And so these patients all had heart disease, diabetes, osteoporosis, thyroid problems, and many other what we call immune suppressed diseases. And many also we found have diminished cognition, and we find that it's very difficult to explain procedures to these, especially when things would go wrong. They would have patients would have a hard time understanding, what we were talking about. Many of my patients I also noticed have diminished cognition. It could be the beginnings of dementia. And I think a lot of the problems we have with our senior citizens, and they get really cranky, is they're starting to get into this beginning dementia. And we're going to start understanding how bacteria, especially spirochetes, get into the nerve through teeth, through the nerves, and also through the blood supply. There's a Japanese study, it's one of the first and the largest, showing diminished cognition and the number of teeth that are missing. They did a very nice study. It showed that the more missing teeth people or Japanese patients had in the elderly, the more diminished cognition these patients have. And this is what I've noticed in my practice as well. August 4th, 2011, we got an extremely important article. And this is the first article, I think it caused the first of these chronic inflammatory diseases to fall. It's the first domino to fall that relates a major autoimmune disease to oral spirochetes. Judith McCloskey had read my first book 3-4 years ago and emailed me, and we corresponded. And then she read the second book, The Silent Saboteur, and then within 6 months of having read that, and we haven't discussed this, but she came out with her article, Alzheimer's Disease and Neurospirochetosis, Analysis of Evidence Following Koch and Hill's Criteria. And she actually went through the dental literature and found enough literature to actually prove with Koch postulates and Hill's criteria that it's time to act. There's enough evidence to show that the majority of Alzheimer's disease is actually caused by oral spirochetosis. Depression is related to periodontal disease, and we know that people with diabetes have a high prevalence of periodontal disease, and depression is higher in individuals with diabetes than those without diabetes. And eliminating a periodontal infection around teeth, the source of the chemicals that cause depression, can be reduced and even eliminated. Depression is related to periodontal disease, and we know that people with diabetes have a high prevalence of periodontal disease, and depression is higher in individuals with diabetes than those without diabetes. And eliminating a periodontal infection around teeth, the source of the chemicals that cause depression, can be reduced and even eliminated. Periodontal disease and rheumatoid arthritis. Individuals with RA have a 3.6 greater risk of moderate to severe periodontitis. So researchers in this area feel that strategies to treat and to control rheumatoid arthritis should include a periodontal assessment. One of the things that we've noticed over the years that the specific finding between the chronic inflammatory diseases is the bone loss finding in periodontal disease. The bone loss finding, during that time of bone loss, we know that probably 80% of the microbes are oral spirochetes. And I've listed these references that go into this in more detail. And if you'd like a copy of those, you can contact me and I'll send it to you so you don't have to copy it off this. Of course, we've known, and over the years, we've been studying the relationship between periodontal disease and chronic inflammatory diseases, specifically heart disease. And I've listed a bunch of references that relate periodontal disease to heart disease. Needless to say, periodontal disease and chronic inflammatory disease represent a huge chunk of money spent in the healthcare system to treat the symptoms and not the cause of the problems in chronic inflammatory diseases. And you can see in 1980, $253 billion was spent on healthcare. 10 years later, went 3 times that to $714 billion. And it tripled again in 2007 to $2.2 trillion. And it's probably much higher today, all treating the symptoms of these chronic inflammatory diseases. I feel that by treating the cause, which is periodontal disease, and eliminate the spirochetes from the gingival sulcus, that we should be able to prevent a large percentage of this healthcare expenditure. Dr. Trevor Marshall is a very famous molecular biologist worldwide, and he has been studying chronic disease for many, many years, and he has what's called the Marshall Protocol. If you're interested, you can Google that name. But he found that there's comorbidities between all the different chronic inflammatory diseases. And he took all of the references from PubMed and from his research, and what he did is he drew these in a circle. And if he studied one disease, like periodontal disease, what other diseases did these patients have? And in heart disease, what other diseases did these patients have, etc., all the way around the circle until he got done and the circle was just filled with lines of comorbidity relationships between all the different chronic inflammatory diseases. Kind of leads to the fact that they're all caused by the same thing. Marshall also in his studies, in collaboration with others, found that there's hundreds of microbes in the mouth. Some are very dangerous. I'm not going to go over all these, but you can look at how many different microbes are actually located in survive in normal saliva of human beings. Interesting enough, 1/3 of the human genome is involved in gingivitis. In other words, when you get gingivitis, that activates 1/3 of the human genomes. The body is building up defenses at the most vulnerable wound, and that's the gingival sulcus. And so the body, over the thousands of years that it's been developing, has developed defenses against these bacteria. And the main entrance of bacteria into the body is through the diseased gingival sulcus. Periodontal disease and systemic chronic inflammatory diseases. The two disease processes are definitely related. Well, how do we diagnose it? Well, there are too many different bacteria right now to diagnose with DNA tests. I know that in periodontal disease we have a DNA probe for one, Treponema denticola, but not the 59 other spirochetes that are involved in periodontal disease. So traditional probing and bleeding points, tissue manipulation, and all that sort of thing that we use now for diagnosing periodontal disease cause bacteremias. Well, bacteremias actually make the disease process worse and allow these bacteria to get into the body. So this is not a good way to diagnose periodontal disease. Right now, the only really good way to diagnose these, especially spirochetes or periodontal disease, is with a high-powered microscope. And with a microscope, you can actually see where the patient is right now, what type of bacteria are more prevalent, and then from that you can devise a treatment plan. The next couple slides I'm going to show their live videos, and thanks to Dr. Paul Kives, we're going to be able to show you these, and I want to give him credit for it. This video is compliments of Paul Kives. What he was showing is spirochetes. They form all kinds of strange things. There's spirochetes that are lined up on that rod that you see right in the middle, and then all the waving motion going on in the center are spirochetes. They form very strange objects, and the more advanced the disease, the more strange it gets. And all of the waving motion you see, it looks like waves, are spirochetes. And then they're attached to rods, and you can see rods forming in the background and moving around as well. This video represents what normal plaque looks like. And this is the endpoint that we're shooting for when we get done treating. The microscopic evidence shows that there's no movement, there's no fast, furious movement of any organism whatsoever. And this is what we're going for, and this is the endpoint we're looking for. Now we're going into a compelling theory of the relationship between dental and heart disease. Study this relationship and you'll understand all chronic inflammatory diseases. Heart disease kills more people than all other diseases combined. Heart disease now kills half of all Americans. Every 26 seconds, someone in the United States has a cardiac event. Once every minute, someone dies. Several years ago, when I first started to get interested in this and started writing a book, this one phrase, every minute someone dies, has pressed me into action, has kept me going through all the thousands of hours I put in on this, studying this subject. And so remember, every second that ticks by, somebody dies of heart disease. When you study atherosclerotic heart disease, it's what an agent called the injurious agent that keeps popping up in the literature. And the researchers don't know what that injurious agent is. In heart disease, the injurious agent attacks the lining of the cardiac blood vessels. Well, we're going to go into studying this, and you'll be able to understand what that injurious agent is before we get finished with this presentation. Next video is we're going to shows a new microprobe. It's an ultrasonic microprobe that is able to diagnose the plaques within vessels, and they're 99% more accurate than what we had with angiograms. This came from a special, it's the Hidden Epidemic Heart Disease in America, and you can go to www.
In the late 1980s, Steve Nissen began working on a bold new idea. He wanted to use the same technique as an angiogram, but instead of making an X-ray image of the center of the artery, Nissen was going to try to use a miniaturized ultrasound probe to scan the cells that line the artery walls. There was just one problem.
At the time we were doing this development, the smallest ultrasound devices were about the size of your fist. And we thought we could make an ultrasound device so small that we could actually put it inside the coronary arteries. Now, coronary arteries are very, very tiny. They're about the size of a pencil lead. And so like a radar dish goes around, it rotates around, sending and receiving these sound waves, just like sonar. And when it sees the reflections come back, it makes a picture from those reflections. I will tell you, it was very frustrating. A lot of the work was done in animals because, of course, you can't test something like that in humans until it's been perfected. And we would go into the animal lab and we would not get a picture. And we would say, all right, let's go back to the drawing board. But by about 1989 or 1990, we were making pictures.
I'm going to go ahead and put this catheter inside the artery, and then I will be able to move back and forth to look at every micrometer of the coronary artery wall.
We put one of these catheters in the coronary artery, and there it was, all that plaque that we couldn't see any other way. You could see on a television screen, just as if you were literally there. And it really was like a fantastic voyage. It was a trip inside the arteries.
The new technology called intravascular ultrasound, or IVUS, was working, and the Cleveland team was shocked by what it revealed.
So here's an example of how much you miss if you just look at the old-fashioned way at the angiogram. And this is an angiogram. You don't have to be a cardiologist to understand it. So you see this is the dye in the coronary, and you see everything's nice and smooth. Nothing is actually narrowed. So now we're going to take you inside that artery, and we're going to show you what the ultrasound looks like. Now remember that the ultrasound is going to look at the artery in cross-section, like you took a sausage and sliced it up. And there's a gigantic plaque, which I've colored in gold for you. And then this is another huge plaque on this side of the artery right there. So those angiograms we'd relied on since 1957. What we realized in the 1990s is that they were showing us 1% of the real disease burden.
The two most important points from this documentary is, number one, atherosclerotic lesions are 99% more prevalent than once understood. The prevalence became evident after World War II. Dramatic increase in deaths caused by heart attacks. In other words, people started dying, dropping dead of heart attacks in large numbers after World War II. So if people were dying in great numbers after World War II, then what happened? Or what happened, and we know that heart disease and periodontal disease are related, so what happened in periodontal disease 20 or 30 years before World War II? Because chronic diseases take 20 or 30 years to develop. So I went into the literature to look for what changed in periodontal disease, and it turned out to be trench mouth in about 1917 in the trenches of World War I. Vincent infection is a spirochete fusiform combination infection. It is highly contagious and spread throughout the industrialized world. Treponema vincini is a spirochetes, or their mutated strains are the culprits of this particular disease. So where did this new strain of bacteria come from back then? Well, there's a couple theories. One theory is that it was a strain that came from some isolated part of the world, where an isolated population where the spirochete somehow mutated into Treponema vincenti and then was carried into the trenches of World War I. And there's another more sinister interpretation or guess of where this origin was, in that we know in World War II the Japanese used spirochetes as a bioweapon. And I noticed in the literature that as far as the way spirochetes act in the spore formation, that was understood at the turn of the century with Noguchi from Japan that studied at the Rockefeller Institute. So it's also in the German literature and the French literature about how spirochetes can transform into spores, and these spores are transmitted by aerosol. So it's very possible that this trench mouth could be the first use of bioweapons in modern times in World War I. Now, after figuring out that possibly heart disease and these chronic diseases might have something to do with a spirochete, I wanted to see, well, let's take a look at other spirochetal diseases. And there are two others that come to mind that are very prevalent. Syphilis is one, by Treponema palatin, and then Lyme disease is Borrelia burgdorferi. And these two I started studying intensely and found some very interesting correlations between these two diseases and the patients that I was doing multiple implants and who had multiple missing tooth syndrome. Now we know that syphilis has 4 stages. The first stage is what we call the primary lesion, and that's a chancre. And then we know if that's not treated, it goes into the secondary or multiple lesions stage, where you have multiple lesions all over the body. And if that's not treated, then that goes in, and the whole disease process goes into what's called the latent stage. And this latent stage can last 30, 40 years until the immune system starts going down. And then we get into what's called the tertiary or gamma stage, which is actually the most dangerous part. And this, once we get into the tertiary syphilis stage, then you have the multiple mental disorders, arthritis, chronic inflammatory diseases, bone lesions, soft tissue lesions, gammas, and atherosclerotic heart disease. All the chronic inflammatory diseases that I name are all the similar ones that my patients with multiple missing teeth seem to have. Now, how did syphilis get to be such a bad bug? Well, if you study the origins of syphilis, it actually did start in Europe, and it went through the Bering Sea, the land bridge, into the Americas, and it stayed there for thousands of years. And it developed and changed slightly. And then when Columbus came over in 1492, it went back with one of his shipmates, and it caused a huge epidemic in Europe at that time because the strain of syphilis had changed and morphed and mutated into a more virulent stage to a population that didn't have immunity for that particular strain. Now, I'm not going to go over this list in detail, but you can see how many famous people actually contracted syphilis, and then a lot of them died from it. So if you take a disease that in the Americas that it wasn't causing much of a problem, but we transmitted that into a population that didn't have immunity for this particular strain, it was very devastating. So in syphilis, and I'm going to make the comparison between periodontal disease, Lyme disease, and syphilis, but how many chancres does it actually take to get syphilis? Well, the answer is 1. Now we're going to get into Lyme disease, and Lyme disease is an extremely controversial disease over the last few years. And I could go and talk about this ad infinitum, but I'm probably trying to get through this in a simple way as possible. It's a chronic inflammatory disease. It's very similar to syphilis. It's very difficult, if not to cure, once it becomes chronic and embedded into the body, similar to syphilis. And the symptoms, once you get into the stage, if you don't catch Lyme disease with antibiotics immediately, then it goes just like syphilis into a latent stage. And once it gets in a latent stage, it's called chronic Lyme disease. Chronic Lyme disease is all the symptoms we just described for tertiary syphilis and multiple missing teeth syndrome. It's heart disease, mental fog, multiple mental disorders, arthritis, chronic fatigue, muscle weakness, bone lesions, periodontal disease, and multiple of the chronic inflammatory diseases, same as the other syphilitic, or the same as the other spirochetal long-term chronic manifestation of spirochetosis. Now we talk about the origins of Lyme disease. Probably the original strain started in Germany, and then it was also reported in Sweden in 1909. In 1922, it was found that they caused neurological problems, and in 1970 it was found in the United States, and 1981 Borgifer found that spirochetes is what caused Lyme disease, and it was transmitted by a tick. And it gets into even more detail. The more you learn about Lyme disease, the more you realize that it very well could have been a bioweapon that was being studied in Plum Island on Long Island, and it somehow got away. The researchers didn't realize it was transmitted by ticks, and the animals they were studying were outside, and the birds in their fly zone were there, and the ticks get transferred. And since this disease, the Lyme kinetic is right across the causeway from Plum Island, and then from there, that is the target, and the disease is spread all around the world from there. But we're not pointing any accusatory fingers at anybody. It was just ignorance, and it wasn't done intentionally, but probably that is how Lyme disease got started. Again, we talked about how many chancres it take to get syphilis, and well, how many tick bites does it take to get Lyme disease, and that's 1. And what I'd like to point out is that periodontal disease, patients had episodes with periodontal disease throughout their life, but which one of these episodic incidences did they actually develop chronic oral spirochetosis? Well, obviously it might only take 1, even though a lot of these patients have periodontal disease for many, many years. So you can imagine how many spirochetes have access to the bloodstream in the body with someone that has chronic periodontitis. So what in the world does trench mouth, syphilis, and Lyme disease have in common? Well, we've discussed that already. They all have a spirochete that has gone from one population, has changed and gotten into a new population. As we know, Since we've had trains, planes, and automobiles that in the last 100 years our normal commensal bacteria might be normal if we're in a small isolated community somewhere in the world. But since we're communicating, we're traveling all around the world now in the last 100 years, that we're passing around our bacteria that's slightly different in different populations. So people don't have immunity for these slight changes, and that's what's causing this chronic disease epidemic, along with some of the terrain changes in diet and sugar and carbohydrates and lowering the immune system. So we kind of get a double whammy there. We're getting a little bit different bacteria that our immune systems aren't used to, plus a diminished immune system because of our diet. And then the disease process caused further diminished immune response, and that's now resulted in probably 80% of the population in industrialized world worldwide have this have one degree or another of one of these chronic inflammatory diseases. Now, when I studied Dr. Trevor Marshall's wheel, where he took all the chronic inflammatory diseases and put them all around a wheel, then I just put periodontal disease on top, and then I went through my patient charts and then just pointed to all the different diseases my patients had. And we could see that these patients, you could almost from that study alone see that everything seemed to lead to Rome, that all the chronic inflammatory disease, what was in common to all of them was periodontal disease. So we're going to get into a little more detail on how the periodontal bone loss finding and how it's related to chronic inflammatory diseases. We know in heart disease and upper gastrointestinal cancer and stroke, head and neck, esophageal and lung cancer, tongue cancer, and atherosclerotic risk. Now, alveolar bone loss was associated with a 5.23-fold increase in the risk of tongue cancer. Severe periodontal bone loss was associated with nearly 4 times or 4-fold increase in the risk for presence of cardiac artery plaque, and there are the references. According to Richard Ellen, who is probably the premier spirochete expert worldwide, especially oral spirochetes, he said that periodontal bone loss is always associated with predominance of oral spirochetes. Here's a list of references that show the relationship between the bone loss finding and the various chronic inflammatory diseases. Well, it begs the question, we've known about spirochetes for 100 years. Well, why haven't we understood this sooner? Why hasn't this concept surfaced sooner than it is now? Well, the reason is that we didn't understand the life cycles of spirochetes and how they're pleomorphic and how they have they've got at least 4 different forms, and we only recognize 1, maybe 2 of these forms. At least clinicians don't recognize these forms. There's been research articles on all these forms for many years, but evidently clinicians don't read the scientific literature or the research literature, otherwise this would have been known a long time ago. Amazingly, in the earliest part of the 19th century, we've known that from the literature, the French literature, that they've noticed just with dark field microscopy that spirochetes at the end of their life will form these little granules inside the body of the spirochete. And as the outer membrane breaks down at the end of the life of the spirochete, there's maybe 16 to 8 little granules. And they found that when they separate these granules and put them into fresh culture, that they transform into spirochetes. Here's another reference in the French literature in 1912 showing this production and a drawing that the researcher did at the time, how a spirochete will break down at the end of life and produce these spores, or what are called granular bodies. Each one is capable of producing a spirochete. Ellen McDonald, very prominent Lyme disease expert, found what are called cyst forms. And of course, cyst forms have been known for a long time as well, but he found these in Lyme disease and Borrelia burgdorferi. And he felt that these cyst forms he found in Alzheimer's plaque, in Alzheimer's brains, and also in the nerve tissue, he felt that that stimulated amyloid production, and that they actually, even in that form, can stimulate the immune system to defend itself in creating plaque, the amyloid, which actually is an antimicrobial to defend itself against Alzheimer's disease. In McDonald's research, he did these antibodies, the fluorescent antibodies, and they're specific for various spirochetes. And he showed these little granules inside the spirochetes, and eventually they break down, and once they enter the cytoplasm or into the tissue, these each can form a new spirochete. McDonald also found in Alzheimer's patients in the nerves that the spirochetes have an affinity for nerve tissue, and they can actually run up along nerves. And in these slides you can see that not only do we have live spirochetes, but also these granular structures or cyst forms that you can see actually in the nerve trunks or the nerve endings in the brain. And again, Alan McDonald felt that these cysts could actually stimulate an immune response, and this immune response is what's responsible for the chronic inflammatory diseases. And he studied specifically Alzheimer's disease, and this is what he found in Alzheimer's patients. Here's a list of the Lyme disease spirochetes. So there's not just one strain of these particular organisms. In Lyme disease, there's 20 some odd or more strains of Burgdorferi, and then of course in oral spirochetosis there's about 60 different strains of treponema, or different forms that are discovered, most of which cannot be cultured. So to diagnose them, you can't use a DNA test because, or you can't culture them. You can use DNA tests, but the thing is they're not available for the clinician. So the only way really to diagnose these is with a microscope. This is a video sequence taken from Lyme disease research, and this is actually tissue and a Lyme disease lesion. And the Lyme spirochetes, you can see them moving like little snakes, and what we need to point out is they can move from one area to the other very easily. And here goes some phagocytosis by a lymphocyte, and we'll find out later the significance of this and whether or not that spirochete was actually destroyed within that lymphocyte, or did it survive to form another form that would take over the lymphocyte. In the previous video you noticed that a lymphocyte engulfed the spirochete, and what happens there is that you see phagocytosis and you see engulfment, but are these phagocytes successful in eliminating or causing these spirochetes to actually vanish and not cause disease? Well, we'll be talking about that later. Here's a slide of successful phagocytosis, and this phagocyte, you can faintly see the outline of a spirochete in the top part of the cell, and it's undulating very slowly, and within the cytoplasm you see these granules. And we're going to discuss these granules later, but according to research that goes back for almost 100 years, it shows that these little granules that form inside a dying spirochete actually each one, if placed in fresh culture, can produce new spirochetes. Now as this starts to slow down and the spirochete is being phagocytized, you see the little granules being released one after another. You can see one released right now, and right near the middle you'll see another granule, and pretty soon all those granules that are inside that spirochete will be released into the cytoplasm, and then you'll no longer see the form of the spirochete anymore, because the whole thing would have been phagocytized. But the granules are released within the cytoplasm of this phagocyte, so the actual offspring of the spirochete did actually survive, and this is proof of it right here. Now there's no sign at all of that spirochete inside that cell any longer. This is actually a Lyme disease spirochete, and the researcher has set it up inside a slide, and these are from pure culture from Borrelia burgdorferi, and you can see objects flying by, but he's got a wicking of a very dilute solution of penicillin going through, and he's watching these spirochetes as they react to the penicillin. And see, they roll up into that little spore-like form, or what he calls a cyst form. Now it's going to go in slow motion. You see how it starts to turn at the end, It forms kind of a club at the end, or a blurb, or a bump, and then within a very short time the thing rolls up to form what we call the spore-like form or the cyst form. When I first found out about spore formation in Lyme disease and syphilis, I went looking in the dental literature. And so I got every textbook I could find at UCLA, their old library. And I found one textbook back in 1960 that referred to these granular bodies, and he found that they broke down similar to what is reported in the literature. And then when he moved these little granular structures of fresh culture, they did actually produce spirochetes. Wolf and her colleagues in Germany did some wonderful electron microscopy slides and studies of spirochetes and how they change forms. They found that they roll up on themselves and they form what's called a club form, and then they compress further to form these larger spores and then into a much smaller spore-like form. And they did this research with pure cultures of spirochetes so that nothing would interfere with it. And they did it with frozen sections so that they do scanning electron microscopy. Just recently, in 2011, June 2011, Dasper reported with scanning electron microscopy the relationship between spirochetes and these little spore formations, and he shows them, and you have to study these very carefully. In fact, you can go get this article online and you can read this article, but he points out
back
that
in 1948,
these little spore forms are
of these
found in
granular
epithelial
forms with
cells, and
scanning
he
electron microscopy.
conjectures that these
And they
spore-like
found at high
forms in the
power
epithelial
that these
cells of the
spirochetes
gingival
do form
sulcus is the
these, what
reason
we call
why
granular
we have
forms.
difficulty in treating periodontal disease. Because if you don't get the spores from the epithelial lining, it just repopulates the gingival sulcus. So based on these findings, in that we've also found these spore-like forms in the epithelial lining, so we feel that treating patients with a laser and just doing a curettage, a laser curettage of the gingival sulcus and removing that gingival sulcus or the lining, that we can get rid of these spores and thus increase our success rate in the treatment of periodontal disease. In the next slide, we're going to see a sample, and this is one of the first samples that I found these spore-like forms in a macrophage. And I was doing a root canal, and I actually had perforated through between the crown and the root, and I didn't realize it, and caused bleeding. And at first I thought it was just bleeding from the nerve chamber, but I took a sample and put it on the microscope, and you can see these little spore-like forms in this. It looks like a lymphocyte, but it's a phagocyte of some sort. And I feel that this is what's called the injurious agent, and it's probably the basis of all chronic inflammatory diseases. No matter where you look in the body, you find these little cyst forms. This is another phagocyte, and within the cytoplasm you see quite a few of these little cyst-like or spore-like forms within the cytoplasm of this immune cell. And you notice that there are red blood corpuscles right next to it. So we find these. This one came from the gingival sulcus that had red blood cells in it, but we also find these actually in the bloodstream as well. This sample was taken actually from a blood sample, and here's one of these spore-like forms in a red blood corpuscle. It's quite amazing. These things are spread everywhere around the body. Here's another one of these bodies that's just floating freely in the blood. You find these all the time, and they have that typical flat black donut shape with that white opalescent center that we see so typically in the gingival sulcus. When I'm finding these little spore-like forms in different epithelial cells throughout the body in different diseases, Judith Miklowski sent me a sample of of the pancreas and the Isles of Langerhans. And if you look very carefully, you'll find these little spore-like forms in the Isles of Langerhans as well, which seems like all roads lead to Rome. And all these chronic inflammatory diseases, when you study them and the power of 1,000 to 5,000 power where I'm studying them, you find these spore-like forms in all these different diseases, especially associated with epithelial cells and epithelial linings. One of the things I do when I do a plaque sampling with a microscope is that when you do a scraping from a gingival sulcus, I usually do it from the gingival pocket on the lingual side of the second molar, because there's always a 3 to 4 millimeter pocket there, and it's always the hardest area for a patient to clean. So I usually go back there with a little curette, a little Gracie, and I take a sample of plaque from there, and you almost always get epithelial cells. And this particular slide shows an epithelial slide just loaded with these spore-like forms. Usually you'll see in periodontal disease, you'll see various numbers of these spores or spore-like forms within those epithelial cells. There's research that show that spirochetes can transit through epithelial cells, and that there's research that the DNA of these spirochetes are found in these cells, but in studying these over the years, I've only seen one spirochete in an epithelial cell, but I see hundreds of slides with cells loaded with these spore-like forms. And I'm very convinced that these are spirochetal spore-like, but we don't know for certain because we haven't been able to do the DNA tests on these yet. But the monies are being raised right now to get this final step done in this research to verify that these are actually spirochetal. During treatment of periodontal disease, intracellular spirochetal bacteria are less likely to be physically removed by scaling and root planing and are more resistant to antibiotics. Furthermore, this intracellular population could constitute a reservoir of bacteria for the repopulation of treated gingival sulcus sites and refractory periodontitis. And that's a quote, and this article just recently came out in the last year. So even our researchers in the most prestigious journals are recognizing that spirochetes in the gingival sulcus, in the epithelial cells themselves, seems to be why we can't get rid of periodontal disease. So we need to pay acute attention to this and start designing our treatment modalities, such as laser treatment, to actually obliterate the lining of the gingival sulcus and get rid of the source of this bacteria. Now we're going to kind of get into the theory of why and how spirochetes cause immunosuppression. The Lyme disease spirochete, Borrelia burgdorferi, has the ability of infecting the inside of cells and of converting vitamin D to immunosuppressant hormone known as 1,25D. The whole vitamin D complex is very interesting, and is a very, very hot subject today, and we're going to discuss this in some detail here in a few minutes. Anyone that has chronic inflammatory disease of any sort will show a low value for what's called 25-D. It's vitamin D. It's one of the precursors to the actual 1,25-D, which is a steroid, and that's the active vitamin D. But we find in chronic disease that the level of 2,5-D is always low. Now, the normal mechanism of the biosynthesis of vitamin D, it all starts in the skin. The sun converts cholesterol to the first precursor called pre-vitamin D. And then there's a sigmoided shift that creates the next step in the vitamin D production. Then there's another shift that takes vitamin D, or what we call 2,5-D, into vitamin 1,25-D, which is the active steroid. And that is produced in the kidneys. It's a renal function, and that is what we call the normal renal production of 1,25-D. It's a steroid that modulates the immune system. And that's how normally if you get an infection, the body will sense it. 1,25-D is produced, that goes out and it stimulates the innate immune system. The innate immune system then finds the bacteria and destroys it. And then all those vitamin D levels go back to normal and everything goes back the way it was. That's what happens in the normal immune reaction to a bacterial attack. However, in chronic disease, we have a battle going on between the innate immune system and the bacteria over millions of years learned how to defend itself against the innate immune system. And what happens is the phagocyte will ingest, for example, a spirochete, and there's many other bacteria that can do the same thing. But once the bacteria gets inside the cell, inside the immune cell, it transforms into what's called a cell wall deficient form, or a CWD. And when that happens, then that takes over the machinery of the DNA within the cell to produce blocks that go on what's called the vitamin D receptor, the VDR receptor, and it blocks the innate immune system. At the same time, 2,5-D is continually, because since the immune system is blocked, the immune system is still calling for more immune reactions. So more and more 1,2,5-D is accumulated from what we call extrarenal sources, and others from the phagocytes themselves are producing the 1,2,5-D, and it's a dysfunctional form of vitamin D production. And so what happens is the 1,2,5-D rises, and then the T regulatory cells then see that there's enough there, and so it shuts down the immune system. So basically the bacteria control the immune system by shutting it off in the front door, and then it goes and shuts it off in the back door when 1,2,5-D gets to a high level. So in other words, 1,2,5-D, which is a normal steroid that modulates the immune system, gets high enough, it turns itself into immunosuppressant. So this whole deal with vitamin D and giving people with chronic inflammatory disease more 2,5-D just produces more 1,2,5-D, which is a dysfunctional immune system, actually is bad for the patient. Early on in the disease, before it becomes chronic, vitamin D and increasing vitamin D might be good. But the research still needs to be done, and the jury's out on how we treat patients with vitamin D supplements and that sort of thing. But right now, I do it very cautiously. So as we said before, cancer is associated with decreased vitamin 2,5-D. Lyme disease is also associated with decrease in vitamin 2,5-D, as well as all the chronic inflammatory diseases are all related, as well as periodontal disease. So when you test these patients, they all show a low 2,5-D. And when you show a low 2,5-D, that usually indicates the patient has a chronic inflammatory disease one place or another. So then what happens in the disease in the gingival sulcus? Well, once the bacteria reach that certain concentration of whatever it is, it may be a virus that starts it all off, and then the immune system is altered so that it can't attack bacteria according to Jorgen slots, or whether it's the combination of different bacteria. Then we know that, like the red complex with Porphyromonas gingivalis and the AA and the other bacteria that are needed for the proliferation of oral spirochetes. But when that starts to happen, it stimulates the immune system, and signals are set out, and then the pathways of the immune system are opened up and begin to flow into gingival sulcus. And then you see swelling, redness, and then bleeding gums. And as soon as you start seeing the bleeding gums, then it's gotten to the population where you're going to have bacteremias, and bacteria is going to be able to escape from the gingival sulcus into distant organs and start setting up foci of infections everywhere in the body, anywhere the spirochetes can actually get, and it's been proven that they can get anywhere in the body. And then the bacteria in the body start this conflict, this war. And then after a while it sets up, it becomes chronic, or a stalemate. And the bacteria produces immunosuppressions, which suppresses the immune system. And so patients with multiple missing teeth or periodontal disease, and those are the patients we treat for dental implants, for the most part, are immunosuppressed, and they're vulnerable to infections, and those are the ones we have to watch very carefully. And also we want to diagnose this before we start implant therapy, so we can warn the patient if they do have infections that we can treat the infections, but not to get excited that the procedure is going bad or anybody did anything bad. It's just that their immune system isn't what it should be. So we need to immediately be alerted to the fact that the implants, the tissue's bleeding, and if that's happening, we need to treat that immediately. So our patients know that when that happens, they need to come back to the office and we need to deal with it immediately. So immune suppression links all of these chronic inflammatory diseases. Spirochetes, along with several other bacteria, are capable of doing this immune suppression. So we as dentists, as far as oral spirochetosis, would be the ones to diagnose this, and once we diagnose it, then it comes time to eradicate oral spirochetes. I don't know of any spirochetal disease that's good, and obviously we've patronized these spirochetes long enough, and now it's time to diagnose and begin treating them and saving our patients from, for example, the ravages of Alzheimer's disease. And we're going to be responsible for treating this and to eliminating this, and eventually it'll become the standard of care. And if you don't, then there'll be probably legal consequences to that. The following video clip from that same documentary, The Hidden Epidemic Heart Disease in America, this short little clip says it all. And even though the researcher there feels that's unique to the atherosclerotic lesion, if you study all the chronic inflammatory diseases, if you get right down to the little foci of infection, they're all produce the same type of lesion that you see in heart disease, including periodontal disease.
What we have appreciated more and more is that the atherosclerotic plaque itself is filled with cells that are busily at work exchanging messages.
The plaques send messages that spark the immune system into action. Sensing there are foreign invaders in the artery walls, the body does what it would do with any other infection or irritation. It responds with a cascade of chemical reactions that create inflammation at the site of the plaque. White blood cells come to try to help heal the inflamed site. Anywhere else in the body, this would be a normal, healthy reaction. But in the heart, once the white blood cells arrive, they're trapped in the plaque and can't do their job. Instead, they trigger even more massive inflammation.
The same warriors that we use to fight off invaders are turned against us and become, indeed, the disease itself.
The basis of all chronic disease, and I repeat, is rooted in the inflammatory response and immunosuppression by bacteria, and a large percent of them have to do with oral spirochetes. In the mouth, the two main sources for these open wounds is, number one, periodontal disease, and doing mathematics, you can actually figure out how big that wound is. If you figure it out, in advanced periodontal disease, the wound is as big as the palm of your hand. If that wound existed anywhere else in the body and it persisted year after year, you'd probably die from it. You probably wouldn't last 2 or 3 months. But because the immune system is so good at protecting itself in that particular area of the body, that it becomes chronic and goes year after year. But it doesn't mean that that patient isn't going to suffer later when the immune system starts going down. Because the immune system just becomes overloaded, and the immune cells become overloaded with these bacteria and pretty soon cannot function anymore. And the other source is root canal treated teeth, and we're not going to get into that too much. That's going to be another lecture down the way. But the same bacteria are associated with root canal treated teeth as well. For example, there's literature out that show that 50% of root canals still have infection associated with the apex of the root. We found, and I published papers on the fact that adjacent implants fail next to this infection. And we think that implants, if you want to find out if there's any infection in the mouth, put an implant in, and if it fails, you're pretty guaranteed that there's an abscess tooth or a crown tooth that's necrotic or a root canal tooth that still has bacteria associated, which cause the implant to fail. And this begs the question, if a root canal treated tooth can cause an implant to fail, what is that foci of infection, that root canal tooth, doing to the rest of the body? And I think we as dentists need to answer that question. And we talked about oral spirochetes being associated with root canal teeth as well. And there's several articles that show that different spirochetes cause these problems, and there's animal studies that show the same thing. Here are some of the articles and references that talk about root canal teeth and the problematic nature of the bacteria associated with these root canals and what they possibly can do systemically. So now that we have studied the spore-like forms and the fact that spirochetes produce these things, about three years ago I decided to see if I could find these same spore-like bodies in my patients. So I started examining plaque taken from patients with severe periodontal disease and hoping to find and looking for these spore-like forms in my own patients. And what I found is that we would find some spore-like forms, but once I treated them with antibiotics and then treated them during the second week of the antibiotic course, that I would find huge numbers of spores that were floating in the fluid or in the plaque sample. So I tested patient after patient, and you'll see as we go along that we were finding these spore-like forms in our periodontal patients as well. The first patient was a 43-year-old Caucasian female. She was kind of a high-strung, emotional type of person and had a poor skin complexion and had periodontal disease, and we ended up taking out several teeth, and it was a very complex case. We did put implants in, and then we followed her very closely over the years. But about 10 years after we placed the implants, within a fairly short time, because this patient actually did follow up fairly closely with us, and she developed an infection. We took x-rays and found that she had dramatic bone loss from one 6-month appointment to the next. And the photograph that you're looking at, she ended up losing that implant and the tooth adjacent to it. And before we took the teeth out and during the surgery, I took samples of the plaque and also samples of the granulation tissue and to look at it to see what kind of bacteria we had. This represents a plaque sample from the gingival sulcus, and also I did a swab from the granulation tissue, and we found these strange colonies of spirochetes, and you can look carefully, you can see the tightly wound spirochete that's coming out the right side of this colony and also in the inferior part of it. But this patient had spirochetes throughout. Then what we did is after diagnosing this, we put her on some very heavy antibiotics. It was Flagyl 500 milligrams along with amoxicillin 500 milligrams for 14 days. And then during that second week, we had the patient come in and we took further samples of her plaque to see what would happen or see how effective the antibiotic was. When I did a plaque sample after the antibiotic treatment, we found these little bodies, little flat donuts, and when we panned in and out of them, we found morphology that represented a flat donut with an opalescent center. When we did stop action photography on this, it was very hard to identify the morphology of these particular spore-like forms until I did stop action photography, and I just went click, 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 and you could then take those little granules you saw floating around and we could separate it out. And the picture you see there is the spore-like form is about a millimeter across if you're looking through the monocular. So it's about 1 micron in diameter. And this is the morphology of these spore-like forms that we found in this patient after treating the patient with the antibiotic. So obviously, when we treated with the antibiotic, it was only causing these spirochetes to take on a different form. As we showed you earlier in the presentation, they just roll up into these spore-like forms and are protected there from the antibiotics. The next patient is a black 50-year-old female, family history of heart disease, and she'd had 5 previous periodontal surgeries. And what we found in this lady is that she had one tooth that periodontal disease seemed to be picking on. And when we took a sample of this, we found what's called a colony with these colonies, in this particular case, had at least 200 or 300 spirochetes and probably more that were associated with the colony. And she had multiple colonies throughout her plaque sample. And we find these colonies be present in Lyme disease patients as well. And this is where I learned about colonies, but we now know that these same colonies exist in the periodontal disease and the periodontal sulcus. Here's a tooth, was number 19, and you could see the periodontal pocket, but it was quite amazing to see what the bacterial flora was in that pocket and the predominance of spirochetes. And we know from earlier in the presentation that it's the bone loss part of periodontal disease that is associated with high numbers of spirochetes. This sample represents hundreds of these colonies, and each colony had hundreds of spirochetes projecting out from it. But as we looked at the sample, we watched these things for many hours. It was truly amazing to see all these spirochetes. This is so typical of hundreds of samples that we've done over the years, where after antibiotics, when we check the plaque sample, there are no more viable spirochetes, but they have the granular forms all over and throughout the whole sample. In these samples, we also found clumps of what we thought were spore-like forms, and if you look very carefully in the middle of the slide, they're they're flat donuts. In these cases aren't completely round like most of the spores we see, but we feel that this is associated with the resting stage or the spore-like forms produced by spirochetes treated with antibiotics. The next patient represents a patient that I treated for many, many years, 12 years. We placed what's called a custom endosteal implant. Many of you know them as a subperiosteal implant, but the subperiosteal implant is a fibro-integrated implant, where a custom endosteal implant is a totally osseous-integrated implant. But this patient had periodic infections over the years, and we treated with antibiotics. And then a few years later, he'd have another episode of infection. But his health history, he had a health history of heart disease and high blood pressure, and he presented to the office with these snags of teeth that were, I couldn't barely find one good tooth in his mouth, and it was very severe periodontal disease, and he already had many missing teeth and a lot of bone abscesses in the bone. So at the time, I had no clue about any of the, how spirochetes produce these spore-like forms, that they sit there, and when you try to do the implant procedure, those spore-like forms can regenerate and produce periodontal disease around the implants. In the bottom slide, you can see the custom endosteal implant and the root form implants. And the bone loss occurred on all of the implants, but the upper implant is the one that we're going to talk about in a minute. When we did initial microscopic on this patient, he had these little spider forms, and we see these all the time with patients with periodontal disease. But they're a little granular form in the middle, and it has multiple spirochetes attached, and as it moves around, it moves like a spider as it goes back and forth. This is a case that, and the only case I've ever seen after heavy-duty antibiotics, 500 milligrams each of amoxicillin and flagell, that we had live spirochetes left in the sample. Obviously, over a long period of time, this patient had several infections and treated many times with the antibiotics, and so they became resistant. The interesting thing about this case is that we put them on heavy-duty antibiotics, amoxicillin and flagell, 500 milligrams each. And we found that during the second week of the antibiotic treatment, when I did my plaque sample, that we found viable spirochetes that were resistant to even this very powerful antibiotic combination. The patient wanted to save his implant and wanted me to do a revision and try to save it. But when I found active spirochetes, I felt that it was pretty hopeless that even with our most powerful antibiotic, we could not control this patient's chronic disease, and that would always be a problem with recurrent infection. So we removed that upper implant and we did a revision on the lower implants. And we followed this case for 5 or 6 years now, and it's stable at this point. The next patient is an Alzheimer's patient, and this is a very interesting case. This patient has since passed away from this disease, but he had also heart disease and multiple missing teeth. I first met this patient because of his wife. His wife had been treated for periodontal disease and couldn't seem to control her large amounts of calculus that she formed on her teeth. And we saw her once a month and scaled her teeth, and she was a tremendous calculus producer, and we never could get her totally under control either. But one day she told me about her husband who had Alzheimer's disease, and he was in the office, and I said, well, I'm very curious to see what the bacterial flora looks like in Alzheimer's patients. So we brought him in and I examined him, and we found, you know, every type of bacteria you can imagine, and we're going to show you a video of that shortly. But at any rate, we decided to treat his periodontal disease, and it was a very interesting case, and you'll see that I learned quite a bit from this particular case. From the Panorex, you can see that he had some missing teeth and he had a fractured tooth, and even though the bone level looks fairly normal, we found a tremendous variety of pathogenic bacteria in his mouth. This video represents Alzheimer's disease, and I showed this earlier in the presentation. But interestingly enough, all of these spirochetes and all the different amoebas and then the trichonomads, this patient developed to the point where he couldn't remember anything. But I did treat this patient with antibiotics, and during the time that he was on the antibiotics, the wife told me a story that they were out shopping and that she forgot her list. And normally he would be the one that remembered everything, but when he'd had Alzheimer's, he couldn't remember anything. But while he was on antibiotics, he remembered everything that was on that list. This Alzheimer's patient was put on flagyl and amoxicillin 500 milligrams each for 2 weeks, and during that last week I did a plaque sample, and we found no active bacteria, or very few, but definitely no more spirochetes. The trichonomads were gone, but what was left are all these spore-like forms that I'm showing you here. As you pan in and out, you can see they're a flat donut with an opalescent center. The next patient came in with Lyme disease, and San Diego isn't a big Lyme disease area, and so I've tried to find every Lyme disease patient I could find and examine their plaque. And this lady came in from Los Angeles, and she brought her husband and her daughter with her, and she had developed Bell's palsy in the upper right, and also she had chronic fatigue and muscle weakness and periodontal disease. She had previously had a root canal treatment on tooth number 3, and then shortly after she had the root canal treatment, she developed Bell's palsy on the upper right. And she suffered with that root canal because it never felt right to her, and there was always a pain associated with it, and she finally had it extracted and then had this bridge that you see placed. Now these spirochetes came from the edentulous area next to tooth number 3. And I'm just showing you a sample of what we found throughout this slide. But there are these little, what we call them spiders. We've seen them before. And plus she had a lot of other very active spirochetes as well. The curious thing with this Lyme disease patient is that when I went to look for plaque samples, I usually go to the lingual pocket of the second molar. And when I took the plaque sample, I couldn't find any spirochetes. And then I remembered that she had had trouble with tooth number 3, so I went and I took plaque samples from number 4 and number 2. And this is where I found the spirochetes, and they were very localized in that one area of her mouth where she actually had developed Bell's palsy. When I diagnosed the problems with this whole family, I placed both the husband and the wife, but not the daughter, on flagyl 500 milligrams and amoxicillin 500 milligrams for 2 weeks. And we also did CO2 laser on both the husband and wife on this case. Here's a Panorex of the husband. You can see the bone level is normal, but it was amazing to see the bacterial flora that he had. And remember, he had tremendous amounts of calculus as well around his teeth. This video represents the husband of the Lyme disease patient that had Bell's palsy. And even though he was diagnosed with Lyme, he had no symptoms, but he certainly had way more spirochetes and what I call very thick, fast-moving spirochetes, which probably will give him problems in the future. I treated him with a laser, CO2 laser, and gave him instructions as to how to keep these things from repopulating his gingival sulcus. The next patient was a 30-year-old female. She had fibromyalgia, muscle weakness, chronic fatigue, and of course multiple missing teeth with periodontal disease. This patient had fibromyalgia, and of course we found spirochetes. And this you have to look very carefully. Right in the center of the slide there's a spirochete that's waving back and forth. And this lady, after we treated her, actually her symptoms did improve. Now, looking at the very top left, you see this snaking spirochete coming down. We think that the ones that snake like that seem to be the more dangerous spirochetes. The next case is a 58-year-old Filipino woman, and she presented with acne and redness above her upper lip, basically her whole lower face. And she just didn't have a healthy look to her skin. It just looked like a gray appearance in her skin. It just didn't look healthy. She had multiple missing teeth. We did implant surgery on her after we treated her periodontal disease. This is the mother of a dear friend, and she had skin that was not clear, a little bit of acne, but just not the supple look of someone who looked healthy. We treated her for periodontal disease and cleared up all her spirochetes, and her face and her skin just look very nice, very young and supple looking. And this is so typical of many of the patients that come in. Their faces are red, their complexions are really ruddy and unhealthy looking. And when we clear their periodontal disease and get rid of all these pathogens that are in their gingival sulcus and the bleeding gums, they all respond in the same way. They get very healthy and their skin looks much, much better. To summarize all these cases, and I could show you cases that represent many other chronic inflammatory diseases, but all of these diseases are characterized by one common denominator, and that's periodontal disease and bone loss. And we found spirochetes in every single one of these cases, and large numbers of spirochetes. And when we treated these cases with antibiotics to be able to do debridement and laser surgery or whatever treatment we did during the second week, we did samples of the bacteria during the second week, and without exception we found spore-like forms in all these different patients, which indicates and which verifies the fact that when we treat patients with antibiotics, the periodontal disease always comes back. And now we're beginning to understand that the gingival sulcus becomes populated with these spore-like forms after antibiotic treatment. And also, we now know that the spirochetes populate the gingival epithelial cells in the gingival sulcus. And then if we don't get rid of these spore-like forms within the gingival sulcus epithelial cells, then the gingival sulcus just becomes repopulated with these spore-like forms first, and then those transform into spirochetes, and then that leads down the road to periodontal disease eventually. So without dealing with these particular organisms, that the periodontal disease will only relapse later, as we well know. And periodontal disease relapse in the vast majority of cases. There's one final piece of the puzzle that was very curious, that I knew if I could find some atherosclerotic plaque, that I was very curious to see if these spore-like forms were in these samples as well. And one of my patients happened to be doing research on atherosclerotic plaque, and he worked with UCSD here in San Diego. And over a period of 2 or 3 appointments, I gained his trust and asked if I could see some fresh samples of atherosclerotic plaque, which he agreed to, and he brought me a bunch of samples. And on all the fresh samples, and these were atherosclerotic plaque taken from the aorta, and we found, which I'm going to show you in a second, spore-like forms in all those samples. And the thing is, they're very tiny, 1 micron across. And I know from my experience in oral pathology and general pathology that most pathologists look at samples at 400 power, and rarely do they ever get to 1,000 power with phase contrast. And also they didn't have electronics to put on top of the microscope to blow it up even further. So these spore-like forms probably would go unnoticed even though they were there. But we found them in every sample that we looked at in the atherosclerotic plaque. Here's an example of one of the samples, the fresh samples of the aorta atherosclerotic plaque that we looked at microscopically. Now these represent fresh samples from the atherosclerotic plaque from the aorta. And these are mounted in paraffin and on microscopic slides. And you can see in the middle where the little O, the donut thing is changing, that's the spore-like form that we found in all the samples that we took from this, from the carotid artery atherosclerotic plaque. So what evolutionary advantage or what survival advantage is it for spirochetes to produce these spore-like forms? Well, number one, the spores that we found in the atherosclerotic plaque means that they're distributed throughout the body in the atherosclerotic plaque, and they can be in any blood vessel anywhere, which includes the meat. And upon the demise of that particular animal or human being, that now in previous days became carrion, would be eaten by other animals, or in the case of humans, they would bury that individual, but in the animals it would be eaten by the next animal. So this is a life cycle of spirochetes, and they get into the meat, then they're consumed, they get into the teeth, and then from the teeth they get into gingival sulcus, and those are the cyst or the spore-like forms. And then once they get into the environment where they can transform back into the helix form, they do, and that completes the life cycle. We also know that spirochetes are transmitted through aerosol, and we know that from the bioweapons research in the Japanese, and that these bacteria were used in aerosols to transmit this disease to other humans. And so that's another life cycle through spirochetes can be transmitted orally by aerosol. And also we know that they can be transmitted just in kissing or contact, fluid to fluid contact. So there's three basic mechanisms where spirochetes can promulgate themselves from one individual or one animal to the next. The lifeguard program is to motivate and achieve compliance with the patient so that they will follow up and see the importance of how oral bacteria can affect their health. We diagnose with a microscope and also traditional methods, and we use them together to devise a treatment plan for each patient. Now we're preparing the slide. We put a little solution on there, and then we put the sample into the solution, and then we place the cover slip on it, and then we flip it over onto a piece of towel paper to absorb the excess fluid, and then we seal the slide cover slip onto the slide. Harvest the sample from usually the most posterior teeth and the mandible on the lingual side, and usually it's the second molar, and there's usually a pocket there that we can take a little Gracie curette and just scoop a sample of plaque as far down in the bottom of the sulcus as you can get. The deeper you go into the sulcus, the more anaerobic you are, and we want the most anaerobic bacteria we can find. But we find this is a very excellent site, and it represents the bacteria flora that's in this patient's mouth. Here's the sample that we harvested. It's the little plaque sample, and we find that if we have a sticky plaque sample, it's usually spirochetes. There's one of the diseases that calls slime disease, and that's a spirochetal disease, and there's a reason why they call it slime, because when you take a plaque sample and it's slimy, it usually has spirochetes associated with it. Now we're preparing the slide. We put a little solution on there, and then we put the sample into the solution, and then we place the cover slip on it, and then we flip it over onto a piece of towel paper to absorb the excess fluid, and then we seal the slide cover slip onto the slide. Here we are sealing the slide. It's like nail polish. It just take a little bit and just seal the edges all the way around the cover slip, and it creates an anaerobic environment for this bacteria. Now we're placing the slide and the bacteria sample into the microscope. Many use a the power of 400. I use 1,000 with phase contrast and oil immersion because I like to be able to see even the smallest spirochetes. We find many samples that until you get to 1,000 power, you can't see the spirochetes. As far as the microscope is concerned, it's good to get a very good quality microscope with good lenses. It's better to cry once than cry many times if you buy the wrong microscope. And we found there is a difference between microscopes, and it's better to buy a very good quality microscope. Here we are observing the sample. We happen to have high definition camera with 18 megapixels onto a high definition screen, and so we can actually take a 1,000 power microscope and we can blow it up 4 times to 4,000 power or even 5,000 power, and we can actually see the activities inside the macrophages or the immune cells. And it's not that it's any more resolution, but it's just larger. We can take, with our electronics, we can actually blow the image 1,000 power up to 5,000 power and actually see it better, even though there's no more resolution. This is our screening form that we use. We can take notes on it as the type of bacteria, the type of movement, how fast and furious the movement is, and spirochetes like small, medium, and large, and we can actually get pretty detailed notes as to what the bacteria flora looks like at any particular time. And then every time we examine the patient in the future, we have a reference that we can compare and follow our progress and document our progress as we move to a less virulent plaque sample. Okay, we're going to be doing a sample, a plaque sample, and we have a curette. It's a SG11/112R9. And what it has is just like a little scoop on the end. And what I like to do is go to the lingual surface or the lingual pocket of the second molar, either right or left, a mandibular molar. So we're going to show you how to take a plaque sample. You usually like to go to the second molar, as that's the least likely for a patient to clean, plus there's usually about a 3 to 4 millimeter pocket. And we go down into that area and we just harvest up a sample. And I don't know if you can see that, but there's a tiny little sample. And we put that on our microscopic slide, and if you want, you can flip this over and then go to another tooth, or you can go to the other side of the arch and get a sample from the other side so that you get enough sample to look at it under the microscope. So I'm going to put a drop of our Aura Prep onto the slide. And then we just take the sample off the, in this case it's a very small sample. We place it on the microscopic slide. And we take our cover slip and just drop the cover slip onto that sample. And we fold it over a paper towel. We're just going to turn this over onto the paper towel and just tamp it out. Just press gently, and then we just dry off the sides. Then we have a sealant. And we're going to coat the cover slip just enough to seal it, because we've got anaerobes inside this cover slip, so we don't want oxygen getting into between the cover slip and the slide. And this seals it off. I don't know if you can see that with the reflection. And so we have our sample, and it's all sealed, and it's ready to go to the microscope. Okay, here's the slide, and we're going to be putting it to the microscope. You slide it in, and then we put a little bit of oil immersion oil on the cover slip, because we're working at 1,000 power with phase contrast with the oil immersion. And so there's our slide, and here's our microscope setup. It's set up with high definition. We've got an 18 megapixel high definition camera to a high definition screen. And we're at 5,000 power, and here's an example of the little spore-like forms in the epithelial cells in this particular patient. So as we move around, we see a lot of spirochetes, and they're moving very fast and furiously. So we consider this a very virulent case. So in these cases, we treat with antibiotics, heavy-duty antibiotics, and laser surgery. Based on the microscopic examination and also the traditional examination of the patient, we develop a treatment plan. If we find that there's small numbers of bacteria, but there's still spirochetes, then we do it by chemical means, by chemical irrigation and placing the patient on hygiene with a water pick type device with either 10 drops of bleach or a little bit of HEPA cleanse in the solution so that they're irrigating on a daily basis with something that actually kills the bacteria. But if the spirochetes are very highly populated and the disease process is more severe, then the first treatment modality is this. After we do debridement, we do laser surgery. And we use a CO2 laser, and we're going to show you how that works soon. The next slide will show a video of actual live surgery that we're using a CO2 laser. And the idea is to completely get rid of the lining epithelial cells of the gingival sulcus. We know that from the research that has recently come out that the periodontal bacteria, especially spirochetes, populate the epithelial cells that line the gingival sulcus. So we want to make sure that we get rid of that lining so that that is not a source of repopulation of gingival sulcus later with these type of bacteria. Okay, this is patient Rick, and he came to me and had this swelling, wondered what this was. As a matter of fact, he's my fishing buddy. We're out lobstering, and he said, "Got a bump under my chin right here. What the hell is it, Doc?" And so I felt it, and at the time it was much larger than it is now. It was probably the size of a big marble. And so we brought him in the office, and we x-rayed and found these 4 teeth here, pretty severe periodontal disease and bone loss, and we sent him out for a CAT scan and saw there's some bone destruction right in here. So we figured it was inflammatory. So at this point now, we're going to remove these 4 teeth and do a laser treatment. He has pretty generalized periodontal disease throughout his mouth, so we're going to use a CO2 laser and just remove the gingival sulcus all the way around through his mouth. And the reason that we remove the gingival sulcus is we now know that the epithelial cells are loaded with spirochete DNA, whether it's in a spore form. We're not totally sure now, but so we'd like to get rid of that epithelial lining so that there's no source of spirochetal spore-like forms or whatever it is that repopulate the gingival sulcus. So we're going to go through this step by step today and show how we treat patients with periodontal disease and how we actually set the patient up for long-term survivability and give the patient at least the best chance of not having a relapse in their periodontal disease. We put the patient on 500 milligrams of amoxicillin and flagyl for 2 weeks, and then sometime in that 2 weeks we come in and do our first debridement. We don't do any probing or cause any bleeding points until the patient is covered with antibiotics, because bleeding points and probing actually cause bacteremias, and we don't want to add to the load of bacteria already within the patient's immune system. But now he's on antibiotic and covered, so now I can go through and I use a Cavitron, and it's a very fine tip Cavitron, and we just go in and we go quadrant to quadrant. And for teaching purposes, I'm only going to do just one quadrant for teaching purposes over at the upper right quadrant. So what we're doing is we're taking this very fine tip and we're moving it very gently back and forth, just make sure that all the calculus is off the surfaces in the gingival sulcus. And we're also feeling, just go down and feel, we can actually tell how deep the pockets are in anticipation of coming back with our CO2 laser, and it's kind of a practice run for the CO2 laser. Okay, we're getting ready to do our laser surgery now. It has a little, what we call a periotip on it. We slide that periotip into the gingival sulcus and just move it gently around the sulcus. And what we're hoping for is that we have the CO2 energy coming out the tip, which actually vaporizes the tissue within 1 millimeter of the tip. And then the tip actually does heat up, so that we're cauterizing the lining of the gingival sulcus. And then we come back later with a periodontal Gracie, and then we just remove that little necrotic area that we obliterated, and then clean it up with a gauze. And essentially what we've done is remove the gingival sulcus, which has the spirochetal DNA or spore-like forms in it, so that we give the patient the best chance of not repopulating that sulcus with spirochetes in the future. So we start all the way back. You've got a wisdom tooth here, and we're going to shield the tissue as much as we can. But with this articulate arm, it isn't that hard to get it back in there. And we just gently move the tip around in the gingival, so all the way down to the bottom. We find that when there's granulation tissue, that granulation tissue will bubble. There's a constant stream of CO2 going through this tip, so it helps keep the tip clear. And see a little bit of bubbling I saw right there? And essentially vaporizing and cauterizing the lining of the gingival sulcus. And see the tissue that we've cauterized on here, and the part that vaporizes goes up in smoke, and it goes up into the suction. And then once I get to a certain point, I'll take the little tip off. Where's our wire? You can see how the tip heats up and it's turned brown. The manufacturer doesn't like me to talk about this, the fact that this tip heats up and that we're actually cauterizing is what? But that's part of this particular laser, and I think it's beneficial, is that we work both from cauterization and from laser energy. But here's, the tip will clog up every now and then, and so I just take a little orthodontic wire and then just push it through it, and this is you can see the wire coming out the end, and so I just clear that wire just to make sure that that tip is open. And we put this back in, and I check maybe every tooth or two just to make sure that it isn't clogged up. And go right back to where we were before. The beauty of a CO2 laser is number one, the laser energy goes only 1 millimeter, so you have a lot of control, and it literally vaporizes. It interacts, so it vaporizes rather than cauterizes. But then in this case, the tip warms up, and we actually do cauterize the lining. Okay, you can see the cauterized tissue right on the lining of this sulcus and at the top. And we take our curette and we just scoop that little lining out. Essentially we've done a gingival curettage. And this tissue, this blighted tissue now, if we put this under a microscope, which I've done, you don't find any recognized cells or bacteria or anything in it. It is totally nondescript tissue, and this is what we're pulling out of this gingival sulcus, and that's the diseased part of the pocket or the lining that we want to regrow into fresh epithelial that doesn't have any DNA of spirochetes or any other bacteria. Spirochetes aren't the only ones that get into the gingival lining cells, and that's, we feel, is what repopulates it once you know, down the road if the patient doesn't do strict oral hygiene. It just shells out very And I want you to notice that when you look at this, we really didn't change the height of the tissue any. The tissue looks about the same height as it did before. And then the last step, we're going to wash this off. And see the little tissue tags, the little tissue tags here? We just take a 2x2 gauze and we just take it and just rub it against the tissue and just massage the tissue with it. And then there you can see it doesn't look like we actually did anything at all. And we come back in 1 week and that'll totally be healed. It'll be like we didn't do anything, but now we know that lining is gone because we saw it being removed with the curette. And so that's the CO2 laser treatment to get rid of the gingival sulcus and treating periodontal disease.
Now that the surgery is over and we've done some follow-up, we actually have 3 follow-up appointments after laser surgery. The first one is palliative. We remove any dressing that might be there and basically check the patient to see how they're doing, and then we might do a little bit of cleaning at that point, but usually we don't do anything except a post-operative visit, the first appointment after the laser surgery. The second follow-up appointment after our laser surgery is what we call lifeguard number 2. And lifeguard number 2 is where we actually do, this is 2 weeks after surgery. We use a Cavitron and basically remove any plaque from the surfaces. And then we use a saturated sodium fluoride solution, which is 4.3%. And we irrigate in the gingival sulcus. And what we'd like to do is react the fluoride to any available apatite that's available in the cementum or the dentin that's in the gingival sulcus. In so doing, we feel that the fluoride will help inhibit further bacterial population within the gingival sulcus. This is our 3rd follow-up appointment after laser surgery. And during this appointment, we also do final post-op check to make sure the healing is complete. And then we use the Cavitron and clean plaque, and then we use a stannous fluoride solution, a 10% stannous fluoride, and we irrigate the gingival sulcus again on hopes of getting fluoride incorporated into any apatite that might be available inside the gingival sulcus, again for prevention of repopulation of the gingival sulcus of spirochetes and virulent bacteria. Hygiene is everything for these patients because bacteria is in the environment. Spirochetes can be transmitted by tick bites, can be transmitted sexually. We know from the bioweapons research that it can be transmitted by aerosol. It can be transmitted through contaminated meat. So these are almost impossible to not have them enter your mouth in some shape or form or be in the food. The daily regimen to keep spirochetes from repopulating the gingival sulcus needs to be done on a daily basis. We feel that a water pick device with chemicals is the best way to do it. Dr. Slotz from USC, who's the chairman of the Department of Periodontics at USC and head of the microbiology testing laboratory, feels that Dakin solution, a 1:30 rinse, or we like to put 10 drops of bleach in the water pick and have them use it every day. And it physically kills any fresh spirochetes or virulent bacteria that get into the gingival sulcus. And then when patients are using this thing, it does kill all the bacteria. So we also like to have the patient on a good yogurt or a probiotic once in a while just to repopulate the gingival sulcus in the body with good bacteria. There's been proven with our methods of diagnosis with a microscope that brushing and flossing does nothing to eliminate the bacteria within the gingival sulcus. It just swishes it and moves it around. It actually doesn't kill the bacteria. So brushing and flossing is good to get food out from, like flossing between the teeth, and it's a good method to get the plaque count down, but it absolutely doesn't kill bacteria. You need a water pick that has chemicals in it to actually kill the virulent bacteria. We find that patients that smoke actually have more severe periodontal disease. I don't know if it's the fact that they're neglecting their teeth more or the chemicals within the smoke actually decreases the immune system. But we find that smokers and like implants will fail more frequently with patients who smoke. So we try to put our patients on smoking cessation programs so that they can quit smoking. We have a condition called residual periodontal disease, which despite our best efforts, patients still have difficulty controlling their plaque and the bacterial flora. But we found that with patients that get on the hygiene that we recommend, when you do your plaque samples, that they will not have the virulent bacteria within these samples. They can get the spirochetes down to very few to zero. And we feel that if the spirochetes are next to zero, then we know that spirochetes are the organism that are most prevalent when we have bone loss. So if we eliminate the bacteria that is causing that part of it, then we can keep the periodontal disease down to a minimum. And if it's down to a minimum, that's probably not going to cause systemic disease. Chronic inflammatory diseases are actually bankrupting our country. These chronic inflammatory diseases are correlated to each other and have comorbidities. When one patient has one chronic inflammatory disease, they usually have many. Spirochetes actually represent when the bacterial flora get out of balance. When sugar, for example, the higher sugar diet and also refined carbohydrates, it skews the bacterial flora toward more pathogenic bacteria. Normally, normal bacteria will help inhibit the bad, but when you get the environment where the bad bacteria overpopulates the good bacteria, that's when we start seeing the disease state. The worldwide epidemic, I feel, is caused because we're spreading our bacteria around. About 100 years ago, when we got planes, trains, and automobiles that allowed populations to spread from one area to another, we all seem to have the same type of bacteria flora in our mouths. But example with spirochetes that we've discussed with syphilis and Lyme disease, that they're different strains. And a population in one part of the world may have a different strain population of these spirochetes than someone in another part of the world. So when we're mixing these bacteria up, our immune systems aren't quite up to it. And this is probably the cause of the chronic inflammatory disease that we see worldwide. Now that we understand the life cycles of spirochetes, now we can do something about preventing them from repopulating the gingival sulcus and causing disease. When periodontal disease is controlled, we know that many of the chronic inflammatory diseases start getting better. In other words, rheumatoid arthritis seems to get better. Arthritis gets a little better. We notice, and there's publications, that the arteries do perform better. The endothelial lining of arteries perform better when the periodontal disease is controlled. And in diabetes, we know that you can start dropping insulin down when patients are under control as far as periodontal disease. So periodontal disease and its relationship to systemic disease, we now understand how important it is and how important it is for dentists to diagnose, especially the oral spirochetosis part of it, and control and actually eliminate that part of the flora. And we find that when patients do eliminate that part of the flora within their mouth and then continue on hygiene that controls these populations and keeps the plaque in a normal balance of bacteria, that patients start to get healthier from this. And based on the knowledge that we have now, we'll find in the future that, and we're going to be studying to see how much patients do get better who suffer from chronic inflammatory diseases. This is seminal research, and we're just now finding out about this stuff, so that more research is needed to verify everything that I've said, and we're working hard to be able to establish and to find treatment modalities for the chronic diseases related to what we understand about these diseases. Thank you for your attention, and I hope you enjoyed this presentation.